I'm Dr. Suresh Ramalingam, Professor of Hematology and Medical Oncology and Deputy Director of the Winship Cancer Institute of Emory University in Atlanta. I'm a thoracic oncologist, and I focus on the treatment of lung cancer and research on lung cancer. How do we approach brain metastases in patients with EGFR-mutated patients? The first point I would like to make here is that brain metastases are more common in EGFR-mutated patients. Approximately 40 to 45% of the patients with EGFR-mutated lung cancer will have brain metastases at some point during the course of their journey, unfortunately. So when we treat patients, we want to make sure that the agents that we use have sufficient CNS activity. When we look at the various generations of EGFR tyrosine kinase inhibitors that are currently available in clinical practice, osimertinib appears to have the most optimal brain activity. Why I say that is based on data from the FLORA trial. As you know, the FLORA trial compared osimertinib to either erlotinib or gefitinib as frontline therapy for EGFR exon 19 or 21 mutated patients. Here, we saw that progression in the brain occurred far less commonly in patients treated with osimertinib. For patients who came into the trial with history of brain metastases, osimertinib had a response rate of nearly 90%. Osimertinib has been shown to have higher CNS penetration in preclinical and animal models. So based on all of these lines of evidence, it's fair to say that osimertinib has the most optimal brain metastasis, anti-brain metastases activity among the current group of EGFR tyrosine kinase inhibitors. So for those reasons, osimertinib is the preferred frontline setting. Now, one question that often comes up is, in a patient with newly diagnosed metastatic non-small cell lung cancer that has an EGFR mutation and also has brain metastases, do we also have to treat the brain with local therapy in the form of radiation, or do we just go ahead and treat those patients with EGFR tyrosine kinase inhibitors? In our practice, and I think this is common across many of the academic centers and community centers, for patients who have small brain metastases that are not symptomatic or that are minimally symptomatic, treatment with TKI as the first step is very appropriate. Most often, these patients respond in the brain. I would recommend a short-term follow-up scan of the brain in addition to systemic sites 2 to 3 months into therapy to make sure that the brain lesions are also responding to treatment. So that allows for preserving local radiation to the brain for down the road in the patient's journey as the clinical picture evolves. When we look at CNS activity across various generations of EGFR TKIs, erlotinib, gefitinib, the first generation drugs, do not have sufficient brain penetration. And that appears to be the case even with second generation agents like afatinib. Dacomitinib, which is another second generation agent, was only studied in patients without history of brain metastases. So we have no information on what the brain activity of that particular drug is. So based on these, we now prefer to use osimertinib in the frontline setting for brain metastases. Further, even in patients with leptomeningeal disease, we have seen activity with osimertinib, response rates in the order of 50%, and median PFS lasting somewhere around 12 to 16 months, even for leptomeningeal disease, which is typically associated with poor prognosis.